And so that sort of was a nice idea, but it was sort of only about 70% of the patients received care within this time, within the first beginning of it. So that's sort of, again, part of it's still in their mission statements and their purposes, but it's not actually in reality working out as well as they want it to. So in 2015, they started up the National Guaranteed Access to Healthcare effort to continue to try and improve access. They've so far spent €1 billion, and there's some improvement in waiting times, but not enough. And in 2016, they started an incentive to make Sweden a world leader in e-health. So for a basic structure, it's managed on 3 levels. There's the national, the regional, and the local. So the national is the central government, and the regional and the local governments are under the umbrella of SALAR, which is the Swedish Association of Local Authorities and Regions. And so the county councils are the region municipalities are local. The county councils are responsible for the funding and organization of all healthcare, including setting the budgets and co-pay rates. And the municipalities are responsible for the routine care and housing for elderly and disabled. And then the central government is responsible for overall health policies, and there's also 8 government agencies, and I'll show a little bit more specifically later. So basically, the basic principles of the Swedish healthcare system is on the basis of human dignity, that all human beings have equal entitlements to dignity and the same rights regardless of status in the community. Need and solidarity, that those in greatest need take priority. And cost effectiveness, when choices need to be made, there needs to be a reasonable balance between the cost measures in relation to improvement in health and quality of living. So just sort of a more specific list of what's what. This is sort of SALAR is over here with the county councils and municipalities. And they're in charge of also the 7 university hospitals and medical care regions. There's 70 county council hospitals as well, and 1,100 primary and public and private primary care facilities, and the dentists. And then the municipalities have the public and private services for elderly and disabled. These are the national organizations that are all health related: the Ministry of Health and Social Affairs, National Board of Health and Welfare, Health and Social Care Inspectorate, Swedish Agency for Health and Care Service Analysis, Public Health Agency, Medical Products Agency, Swedish Councils on Technology Assessment in Healthcare, and Dental Pharmaceutical Benefits Agency. These 3 are sort of the 3 that are overseeing the pharmaceutical areas and approval of medical technology and importing drugs and things like that as well. So their total health expenditure as a percentage of their GDP, over here in comparison, I did a comparison of the US, Sweden, Canada, and Israel, just to sort of give people a sense. So their total health care expenditure is 11.9% of their GDP. That was in 2014. And per capita, that is in US dollars, $5,228. And that's $4,375 public and $58 private. So they actually do rank 5th in the highest healthcare expenditures among the OECD nations. And here's their per capita spending versus the WHO regions, just to kind of another comparison. And their main sources of funding here is for healthcare is basically 83% of it is publicly financed, 57% the county councils, 25% municipalities, and 20% central government, and then private only accounts for about 1%. And this is a picture sort of the health spending growth, but it's from 2012 to 2013. Between those 2 years, it increased 2%, which was 2 times the OECD average. So there's a little bit, they have sort of a concern for rising costs that they need. So more about the healthcare expenditures. So government funding is mainly from taxes, county council, municipalities, they impose proportional income taxes, and then national taxes are from, the national funding is from income and direct taxes. For cost containment, the county councils and municipalities are responsible for setting and balancing the annual budgets. The central government and the county councils also have agreements that last year's on the level of subsidies paid by the government to the county councils for prescription drugs, and they set co-pays. The Dental and Pharma Benefits Agency uses value-based pricing for prescription drugs and reimbursement based on assessment of health needs and cost effectiveness. And it used to be that all drugs were approved or automatically approved for government reimbursement as long as they had a fixed price, but that led to a crazy cost rise and all that. And so contracts between the county councils and private specialists that are based on a tendering process. So cost is one of the valuation variables. So they have contracts they have to follow, but they have to keep within certain pricing, and they can't go over, they can't overcharge their patient. There's also capitation on budgets and costs. So then as far as the areas that they're funding primary care providers, which actually accounts for 20% of the expenditure. Outpatient specialists, they're paid on a per case basis, and hospitals, 2/3 of the hospital funding is from the county council's global budgets, and specialized psychiatric care, disability care, elder and caregivers. That actually, elder care actually accounts for 3.6% of their GDP spending, and they also they can also fund informal caregivers like family members and relatives. In a sense, it's either their relative care benefits by giving them, a stipend, or by giving them an actual job and calling them a relative care employee. So there's that, which helps sort of the burden on the elderly care. And then, so as far as the private insurance area, there's not really all that much going on, just because it's small. It was once really only for their political elite, and then in the 90s they allowed it, they sort of opened it up to an employee benefit, because the faster you can get treatment, the faster you can get back to work. But everybody was worried that this would lead to like a fast track for the rich, and it actually ended up alleviating the crowded public sector, which was nice, but it also eventually, where we are now is that you kind of, well, we'll get to it, but you will need private insurance if you want to get, those faster appointments.
Faster, and also if you want to choose your physician.
Right. So they're saying there are certain reasons why you would buy private health insurance for occupational health services, quick access to ambulatory care, and to avoid the wait list. So as you're saying, you have your choice of doctor to actually go visit, and you have a chance of getting in there before a lot of other people. So this is from 2005 to 2011, and so it's sort of showing the rise in private health care. And the yellow is employer paid, blue is group, and the darker blue is individual. So you can see there is a rise in demand. And by 2016, 635,000 people were on had private insurance, which is about 1 in 10 people. Okay. So as far as healthcare providers, staff and facilities, so private providers deliver about 10% of health services, and 25% is in primary care. There's 2.6 staff beds per 1,000 people when the OECD average is 4.6, so they don't actually have that many beds available. They're lower down on the list over here. And total physicians is 4.1, is for 2.9 per capita, which is they're number 7 in Europe in the number of doctors per capita. And 16% of those doctors are in primary care. The total nurses was 11.2. And then the number of acute beds was 2.4 per 1,000. And just have different fears of that. But so yeah, this is from the picture, and they do have a lot of doctors and nurses, but not that many beds for people to actually stay in, which means that they're sort of promoting outpatient care more so than inpatient care. And they also have a relatively low average stay. It's 5.4 days when the OECD average was 8.1. And they also have one of the highest number of long-term care workers, both in-home and nursing home and hospices. You can see over here, they're at the top of that list of long-term caregivers in comparison to the other countries.
Ariel, let me just interrupt you for a minute to re-emphasize what you just said. You said it, and I just want to make sure everyone understands it. You look at these numbers, there are more doctors and more nurses than the OECD average, and the OECD is the highly wealthy countries of the world. A lot of doctors, a lot of nurses, and very little hospital beds. Okay? And the consequence of that is, as Ariel said, it's moving medical care out of the hospital and into the community. Very interesting to see.
And it's preventive care. It's
preventive care, early care,
promotion.
so primary and secondary prevention, if you will. Okay, just to emphasize that. Go ahead.
Okay, so who's covered? Everyone. There's no actual defined package. The treatments, though, are granted based on their principles of quality, need, cost effectiveness. So it's sort of assessed per what the situation is. But there is emergency coverage for patients from the European Union and 9 other countries with whom they have bilateral agreements with. And then asylum-seeking children and permanent resident children also are eligible for health care. And then undeferrable treatment for asylum-seeking and undocumented adults, like maternity care. So what's covered? The services that they do have include preventive services, primary inpatient and outpatient care, emergency care, prescription drugs, rehab, disability support, transportation, home and long-term elderly and disability care. So as far as primary care, they have team-based primary care clinics, which employ typically about 4 general practitioners, nurses, midwives, physiotherapists, psychologists, and gynecologists, and they're all together in one clinic, so it's sort of a one-stop shop. There's no gatekeepers, but sometimes you would need a referral for visiting a provider outside your county council. And patients have the choice of a public or private practice, and you can register with a provider of your choice. And then your first point of contact is your general practitioner or the district nurses. And the clinics are required to hold after-hours care so that they have, available time after work for those who work during the day. And they can collaborate with other providers in the area. So usually maybe 3 clinics will work together, and one will hold after-hours one night and rotate around. And some specialized outpatient care is also covered within primary care, and the rest is in within private clinics. And then it also, for minor mental health issues, they provide the care in primary care settings. And then as far as the hospitals, there are 7 university hospitals and 7 county council hospitals, where they take care of highly specialized care, acute care, and severe mental health issues. They have specialized psychiatrists in the hospitals. And they're funded by county council budgets, diagnosis-related groups, and performance-based methods, which really measures the quality of care. And the other health services that we have are inpatient and outpatient psychiatric care for substance abuse for all ages, in-home care for elderly and disabled. They actually promote in-home care over institutionalized care. People are entitled and encouraged to live in their homes for as long as possible, and about 7 out of 10 elderly receive in-home health care. And there's 30% private, and the rest are public nursing homes. There's also public health and preventative services, such as screenings for most cancers for early treatment, smoking prevention, and recently there's been an increase in physical exercise campaigns, as well as dental care. That's not the same, but the dental care. So then then in terms of pharmaceuticals, as I mentioned before, it used to be that any pharmaceutical that was given a fixed price would be approved, and that led to a rise in skyrocketing pharmaceutical prices. So in 2002, they set up the Pharmaceutical Reimbursement System, which establishes the Pharmaceutical Benefits Board, which is their acronym is LFN. And so they were a national government agency in charge of determining whether a pharmaceutical device should be subsidized by the state and for how much, as well as how much they could be sold for by the pharmacist, and they oversaw other parts of the market. And they still do. Now they're also overseeing the dental system as well. And they also mandated the use of generic substitutes. So now doctors can still oppose the use of the substitute, but they rarely do. And then patients can also oppose taking the substitute, and as long as they're willing to pay the difference. But mainly generics have taken over. They're about 52% of the market. And also, according to this system, there's no price negotiation, so it discourages drug companies from coming to the government and saying, okay, well, we want to sell it for this much, which would be 30% more than they actually intend to sell it for, so that they actually will have to go consider what would be a reasonable price off of that. And if they say no, they can consider reapplying the next year, or whether or not that's worth it to them, but it's not a matter of sitting there negotiating down prices. And it also sort of stimulates innovation, because if they think they need to, create a cheaper, more efficient drug for these diseases, they're more willing to work on it if they know there's some incentive for it. And as a result, drug prices dropped 15% by 2007. So then this is sort of the list of authorities that it goes through. So it's the MPA, which is the Medical Products Association, is in charge of the top two pieces, which is product authorization and classifications. They're sort of in charge of the drugs and monitoring them and assessing them and saying whether or not they're worth purchasing or subsidizing. And then the Dental and Pharmaceutical Benefits Agency sets the costs, and they decide reimbursement and prices of the drugs and medical devices. And then the distribution sort of follows through with the industry players and wholesalers and pharmacies. And there are, the pharmacies were deregulated in 2009, so that broke up the government monopoly, and the number of pharmacies increased by 50%. Currently there's 5 major pharmaceutical chains, and a few independent pharmacies, and it's for a total of 1,355 community pharmacies. And as far as the financing, 79% makes up outpatient medication, 21 is inpatient and hospital medication, and the drug reimbursements are set on the principles, again, of quality, need, and cost effectiveness. And it's more about cost effectiveness, not cost containment. They don't care necessarily whether they're going to pay a lot of money for a drug if it's really worth that price. So they sort of compare it to the amount of improvement in health and quality of life that they would get for the money, so how much bang for your buck. And so they cover generic drugs up to 52% of the market. They also they give free insulin and free infectious disease medication, which is covered by the county councils. All right, so patient utilization in healthcare. So this is out-of-pocket spending as a percentage of household spending is actually I don't want to fight you, but they do say that it is one of the higher out-of-pocket spending countries in Europe of the OECD nations, but it's mainly for if you're purchasing private services. So if you're just using the public services, you're really not paying much at all. But once you do, in comparison to the other countries, it is actually pretty high. So in general, the utilization, so annual consultations per person was about 2.9, and the OECD average was 6.6. So it sounds like people just don't seem to really be wanting to see the doctor, or they're doing better things to prevent them from getting sick in the first place. And then as far as hospital discharges for acute care, was 163 per 1,000 people. The average length of stay was 5.5 days. Cardiac procedures, they had 225 per 100,000 people. For hip replacement surgery, they had 238 per 1,000 people when the average was 161. So it sounds like a lot of people were breaking their hips in Sweden. And then their knee replacements was closer to the average of 21. It was 135 per 100,000 people. And then in 2015, 66% of people were using prescription medications. 97% of children were vaccinated for the measles. And there was 11% said that there had unmet needs due to cost, unmet medical needs due to cost, and 14% dental. So that's sort of an idea of it's not fully universal, complete, and utter coverage for everyone perfectly, but it's also still pretty good. As far as costs, in terms of out-of-pocket spending, it's 15% of health spending overall, and so it's $787 US per capita, and $489 of that was on medications. The annual maximum out-of-pocket health services costs is $130 for adults, free for children under 20 and for pregnant women, and then anything after the $130 is free. And there's a separate copay for elderly and disabled people. It's $195 a month, so I'm assuming that covers like their medications and health services rather than the other. For anyone that isn't elderly or disabled, they have a breakup of a certain out-of-pocket maximum for their health fees and a certain for their prescription. And then they have the annual max out-of-pocket for pharmaceuticals is $260 for adults, and then for all children in the family collectively, you can say, would be $260 for all of them together. And then as far as dental fees, they're free for children under 20. And then there's a subsidy for preventive dental care of $17 to $35, it just depends on age. And then you pay the full cost of services up to $330. You pay 50% of cost up to $1,643, and 15% of cost for services above that. And a maximum stay day in the hospital costs $12, which is amazing. And the maximum price of a primary care visit is $36, which is also pretty awesome. Alright, so as far as patient satisfaction outcomes, it was ranked 10th in Europe in healthcare by the European Health Consumer Index. In 2015, it was 6th in 2013, so that's something to think about. But they were ranked number 1 in range and reach of services. So the types of services that are available and the reach, I'm assuming that's because most of their citizens live in the similar geographic area, so it's not that hard to get to an actual health provider. Then they have notoriously long waiting lists, which is a problem with all universal healthcare because of rationing. So for example, they had children waiting for psychiatric visits for 18 months to see a specialist. And in general, the patient experiences, 49% said that they were able to get a same day or next day appointment. 64% say it's easy to get care after hours. 19% waited more than 2 hours to see a specialist. The patient satisfaction, 31% say the system works pretty well and only major changes are necessary to make it work better. But most people said that there are some good things in our healthcare system, but fundamental changes are needed to make it work better. And only 8% says that it has so much wrong with it needs to be completely rebuilt. So according to the UN, Sweden is one of the most innovative countries with to long-standing importance between of collaboration between science, entrepreneurs, and clinical research. They're really interested in efficient technology. They have a SUV or USP. They assess sort of the medical technologies that come out to see which one would be the most efficient for them. So they don't just buy any new medical technology, it has to be worth their money and time. So their main issues coming up are accessibility. So the number one issue is waiting times. It's actually even worse in more specialized areas than in general primary care. It's some of the longest waiting lists in Europe. Patients reported the most negative accessibility of any European nation. So it led to a steady decline in rankings since 2013 when it dropped from 6th place to 11th place in Europe, according to the European Health Consumer Index. Now they're up to 10, and hopefully they can change things around a bit. But it's specifically the waiting list, the fact that they can't change their wait times. No matter what they've done, they're throwing tons of money at the problem, and they can't. It just isn't fixing it. That's really pulling down their ranking. Otherwise, they would be great. Everything would be fine. But it's just that, the wait times, because it's actually costly. So in practice, equal access really means restricted access. For those with private insurance, they can get access anytime to great quality healthcare. But for those without, they end up waiting maybe months for treatment, even years sometimes. And the effects are costly. They can cost as much as the procedures themselves. One study of patients waiting for cataract surgeries, there were 1,400 patients, and they spent the equivalent of the cost of 800 cataract surgeries on healthcare just by waiting. And so it's becoming increasingly common to be denied ambulatory care for symptoms like severe burns, blood poisoning, myocardial infarction, and strokes. There's also the more emotional effects, is the loss of dignity, frustration, powerlessness, hopelessness, pain, anxiety, loss of ability to perform everyday activities, loss of jobs, and sometimes people even die. So it's really important to kind of work this out. And so what's being done? The government gives targeted grants that incentivize the reduction of waiting times, and also the National Guaranteed Access to Healthcare effort is trying to shorten the waiting times, and it's had some success, but not in really important things like cancer treatments. So they need to kind of keep working on that. And then the next big issue is going to be immigration. So basically, within the past, 2015 to 2016, it was the highest, the 2016 had the highest number of immigrants in any year in Sweden's history. They had 60,343 people, which was 25% more than 2015. So they now have the highest rate of immigration of any European nation. They're at the top of the list. So with already existing really long waiting times, and just the fact that currently everyone is concentrated in these urban areas, what's going to happen with all of these people coming in? Will they be living also in these urbanized areas, or will they have to move out into the rural areas? Will it make it harder to get access to healthcare geographically? Also, just the number of people getting, adding to this pool of a long waiting list has more people, more health issues. And it's also going to bring in new diseases and new health issues, and they'll have to kind of address those things as well. So it's just sort of an influx of extra trouble for them to deal with, and they already have to sort of focus on how to fix that one little piece, which is just those waiting times, to make their system successfully efficient. That's sort of an ideally efficient system, but kind of gets stuck at this lack of access, and it's only, it can only get worse when you have a huge population boom in here, and it's only getting to be more people than that. And I think that's it. Yeah.
So, Ariel, when I talked about the U.S. healthcare system, I drew a series of circles, different sizes, little arrow. How would you characterize